Welcome everybody to the final lecture series of the semester.
Finally done.
Yeah. I'm very excited that Dr. Janet Turan has come to visit us. She is a professor of public health and director of the Sparkman Center for Global Health. She's also the co-director of the Behavioral and Community Services Corps of the CFAR at the University of Alabama, Birmingham. And she's also head of the Fogarty International Center's Initiative on Stigma and Global Health. Most of her work is in Kenya and Turkey, and actually she has a really strong history of doing work in maternal health. And then she also has a tremendous amount of strengths in her domestic work, working with women living with HIV in the context of healthcare discrimination. So please join me in welcoming Dr. Janet Turan today.
Thank you. It is a real pleasure to be here. I think this is probably the first time I've ever been to Connecticut, actually. And I was really excited to see the snow, actually. We don't get to see a lot of that down in Birmingham. So yes, thank you for the introduction, Lisa. And so today, I'm going to share some of the work and thinking that we've been doing around intersectional stigma and HIV-related health. And I'm sure probably everyone in this room is very familiar with the National HIV/AIDS strategy that was updated for 2020, and I think is still valid under the current administration. But you know, this strategy, which was very comprehensive, really also put a big emphasis on providing care that is free from stigma and discrimination. So, and I think even the conversations that we've had with the director of the CDC about the End the Epidemic initiative, we've really tried to remind people that addressing stigma is one of the most important things that we need to do to end the epidemic. So this is a little bit of a maybe Stigma 101. I know many people in this room may be aware, but stigma was, I think, more popularized by the sociologist Irving Goffman decades ago. And really, he was talking about identities, attributes, or behaviors that can cause individuals to lose social value. So something that's deeply discrediting and really reduces a person from being a whole and usual person to a tainted or a discounted one in the eyes of society and possibly in their own eyes. There's been a lot of thinking and theorizing and research around stigma since then. It's a big field of research, and some of the more modern sort of conceptualizations of stigma, you know, recognize that stigma is a process. It's not just a label or a status, it's a process. And Lincoln Phelan talk about stigma occurring when, one, people distinguish and label human differences. We see human differences. And then in many societies, the dominant cultural beliefs link those labeled persons to undesirable characteristics or negative stereotypes. And then labeled persons are placed in these categories, and so that we are able to, you know, separate us from them. So it's all about power. And then those people who are labeled experience status loss and discrimination that leads to unequal outcomes. So sometimes when I'm talking about stigma maybe in the health sciences field, people like, oh yeah, stigma is bad, it's kind of nebulous, we don't know what it is, but you know, how could it actually affect health? And I think we know from a lot of body of research now that there are very distinct ways that stigma actually affects health. And so one, for people who are living with stigmatized conditions, we know that stigma adversely affects their quality of life, their physical and their mental health. Importantly, we also know that stigma and fears of stigma can make people less likely to practice preventive health behaviors or use the health services that they need. So if they're afraid that the receptionist in that clinic is going to stigmatize them, they may not go in to get HIV care or mental health services. And it's also true that stigma in some cases leads to severe discrimination and violence, which can have adverse consequences for help. So as I mentioned, the stigma research field has been going on for a while. There's been a lot of development, elucidation, and there are some certain different dimensions of stigma that a lot of people talk about that I think help us to characterize and understand a bit more. So the first one is anticipated stigma, and that's what I mentioned earlier, just fears. If people know about your stigmatized status, behavior, identity, that they're going to stigmatize you. They're going to treat you badly. And this is really important in the field of health. There's also normative stigma, or what some people call perceptions of community norms. So in that case, what is your perception about how people living with this condition or identity are treated in the community? And that can feed into anticipated stigma. And then there's what we call experienced or enacted stigma, which are actual, acts of abuse, discrimination, and bad treatment due to your identity. And finally, one that we have found to be really important in the HIV field, and I think in other fields as well, is internalized or self-stigma. And so that's when people sort of take those negative attitudes, beliefs, and things that are out there in society and internalize them and apply them to themselves. And so start feelings of low self-worth, self-blame, feeling bad about themselves because they have this identity. So our group developed a conceptual framework because we really felt like a gap in the literature was trying to, one, understand these nuanced dimensions of stigma, and importantly, what are the mechanisms or pathways through which stigma operates? Because once we understand those pathways, then we can figure out how to intervene. And so this framework, which is published in the American Journal of Public Health a couple of years ago, talks about sort of 4 different categories of mechanisms through which stigma can affect HIV-related health, both directly and indirectly. And those categories include interpersonal factors like disclosure, social support, or psychological resources like self-efficacy, coping. Mental health is a huge pathway for the effects of stigma on health, and we often find that consistently in our work that people who experience especially internalized stigma tend to have higher depression symptoms that lead to downstream effects. And then another important category of mechanisms are stress processes. And I think we're just starting to understand this, that if people are experiencing stigma and discrimination day after day, year after year, that can result in chronic stress processes that may affect either their engagement in services or directly their HIV-related health. So you can see we've got direct and indirect paths. And so there is some evidence that experienced stigma leads to chronic stress, which can directly affect people's CD4 counts and their viral loads. And the mechanism for this is through stress-responsive biological systems. So in one study that I won't talk about it too much today, but we're taking hair samples from women living with HIV to measure cortisol and try to relate that to their stigma and stress responses. So the thing that I'm here mainly to talk about today is intersectional stigma. And so those of us who work with different vulnerable populations, we know people often live with a combination of stigmatized identities. So here you might be a pregnant woman who's living with HIV and so has stigma around being HIV positive. She may experience some extra stigma about being pregnant and bringing a child into the world while she's HIV positive. If she's poor, she might be experiencing stigma around being poor or in her racial ethnic group. So, and these are not additive effects. It's much more nuanced than that, but just to show you how they may often come together in a single person or group and have important effects. So recently, as Dr. Eaton was mentioning, we had a group that was organized by the NIH Fogarty International Center to look at issues around stigma and global health. And I was leading a group that was looking at intersectional stigma, and we had a chance to review a lot of the literature that was available at that time and kind of think about what is intersectional stigma, what do we know, what are the gaps? And so we talked about intersectional stigma it's a field where we can characterize the convergence of multiple stigmatized identities within a person or a group and look at their effects. And it really allows us to think a bit more holistically about really how these different identities that people have affect their behaviors as well as health outcomes on an individual or a population level. And an important part that my colleague Dr. Carmen Logie always wants to remind me is that this approach also examines some protective factors that may result from intersectionality. So like the social support or resistance or coping that comes when people with multiple stigmatized identities come together. So that's another aspect to remember, that it's not all negative. So intersectionality, of course, has been something that's a framework or a perspective that's been talked about in many fields over the years. Individuals as far back as Sojourner Truth have talked about the experience of being a Black woman in a society that devalues both being a woman and being Black. A lot of people think about the work of Crenshaw from 1989, that the term intersectionality was really popularized based on her work, looking at, again, the intersection of race and sex. So really coming out of a critical feminist perspective. But since then, this intersectionality framework has been applied in a variety of fields. And so when we're looking at intersectional stigma from a health stigma point of view, there's some different types of stigmas that can sort of intersect. And this is kind of roughly based on Goffman's original kind of categorization of stigmas. So it could be a case when a person or group are living with one or more coexisting physical ailments, in Goffman's terms, or a health condition that are stigmatized. So someone could be both living with HIV and have a mental health disorder. They could have HIV and TB. And so how does that work when they are facing stigma and discrimination around both those health conditions? But we also look at other types of intersectionality. So we look at how these health-related stigmas intersect with stigmas around, for example, affiliations with groups that are often marginalized in society. So it's race or ethnic group, sexual orientation, gender. And then there are a lot of other stigmas that are based on factors that a certain society or a community may attribute it to one's moral character or behaviors. So things like smoking or alcohol use or substance use or sex work. So all these things can carry stigma, and they can intersect in critical ways and cause really qualitatively different experiences for people. So when we did look at the literature as part of this Fogarty group, and really cross-cutting, trying to look at the mental illness intersectionality literature, the substance use literature, whatever was out there. So there are a group of studies that have used vignettes, and so they describe people with certain characteristics and then measure how much social distance they feel from that person, or how much they would discriminate against them. So in general, you find that people change their evaluations of people based on their constellation of stigmatized identities. And so, for example, when you present a vignette about someone living with HIV, if you also add injection drug use to that, people are going to want more social distance from that person. There's a lot of different findings out there in the literature. When we talk to people that are living with more than one stigmatized identity and do studies, often we find that people's experiences with stigma are exacerbated. They feel like they have higher levels of stigmatizing experiences. But in some cases, having one stigmatized characteristic often even seems to be protective, and you feel less stigma about your other stigmatized characteristics. So it's complicated. But most of the research has shown that we have in the HIV field has shown that experiencing intersectional stigma is associated with worse HIV-related behaviors and outcomes. Now, since we published that review paper in February 2019, we probably finished the review a bit before that, there have been some new papers that have come out that, I mean, there's a lot of work going on. There's a lot of excitement around intersectional stigma right now. And you know, NIH has RFA out on it, and it's something that people are really interested in trying to understand. And so, for example, these are some of the more recent papers. So this is by Quinn and colleagues in Social Science and Medicine, and looking at PrEP and intersectional stigma. And so these researchers found, these were among Black, gay, bisexual, and other men who have sex with men, and found that their perspectives on PrEP were very much shaped by their experiences with racism and homonegativity. That it wasn't just all about HIV-related stigma or being afraid of HIV, it was really these other parts of their identity. Carmen Logie in the University of Toronto has done some structural equation modeling work trying to look at the pathways for intersectional stigma. And we're going to talk in a bit about some of the different ways you can measure and analyze intersectional stigma. But she found that stress around having intersectional stigma identities, as well as lack of access to support, led to increased depression in this population, and that downstream led to lower ART adherence and poor HIV-related health outcomes. And then another paper by people in this room, Dr. Valerie Earnshaw, Dr. Lisa Eaton, did a really interesting study of intersectional internalized stigma among Black, gay, and bisexual men. And this is a longitudinal analysis. And interestingly, what they found is that men who had high levels of racial and sexual orientation stigma before being diagnosed with HIV then subsequently had greater levels of HIV internalized stigma after diagnosis. So, and if you have questions about that work, the authors are here. So, because this intersectional stigma work is so complex, there are a lot of different ways we can try to study it. And it's challenging. So ranging from anti-categorical approaches where we really don't want to put people in simplified categories, to more intra-categorical responses where you try to really explore one set of identities, or intercategorical where you're comparing people's identities. And so this really needs a range of qualitative, quantitative, and mixed methods research. I know some researchers have argued that you can't study intersectional stigma with quantitative methods because, I mean, it's so hard to disentangle, right? People don't always have a clear separation in their mind about, okay, oh, this is happening because I'm living with HIV, and this is happening because I'm Black, or this is happening because I'm poor. So there are some challenges in trying to study it quantitatively, but that doesn't stop us from trying, right? And I think really mixed methods are probably the best way to go to really understand people's lived experience, but also trying to figure out if we can somehow quantify and disentangle the effects. So when you're measuring intersectional stigma, there are some different options. People have done it a lot of different ways. So one, you just might measure stigma related to one specific identity or health condition. So you might just measure HIV-related stigma. There are validated scales for that. And then you just can look at how that stigma experience differs between different subgroups, between Blacks and whites, between young and old, between, gay and straight, so that's an approach that a lot of people have used. Another approach is to use kind of parallel generic questions on experience and anticipations of stigma and discrimination. So you might say, you know, for example, I was treated badly by the receptionist at the clinic. And then you would ask questions about, okay, was that because of your HIV? Was that because you were poor? Was that because, you know, you ask about it in relationship to different identities, or you could even just, you know, use those variables. Another approach which we chose to use in my current study that I'm going to talk about is using very specific nuanced measures for each type of stigma. Because, I don't know, we really feel like each type of stigma and discrimination is really qualitatively different. And so we really wanted to use measures that get into the richness of that experience. And so a very different scale for poverty stigma than the scale that you would see for HIV-related stigma, etc. That again brings some challenges analytically, right? It's not easy if if your items are all completely different. Another thing that people have done is using measures of, they develop scales that are very specific to the intersectional stigma they're trying to study. So, for example, Rosenthal and Lobo developed a gendered racism experienced by Latinas scale. So that's another option. And so these different ways of measurement also come with different analytical approaches. So you could be using moderation approaches where you're just putting in interaction terms for stigma-related variables and seeing it how it differs. You could use multi-level modeling, and that would give you the option to be able to look at both individual level and community level variables for multiple stigmas, and that's promising. Structural equation modeling is going to allow you to examine these complex pathways and relationships among the different stigmas and the way they operate on outcomes. And then what we have been sort of favoring a bit lately or trying out is latent variable, latent class, and latent profile methods. So, and that's where we can create sort of classes or groups that have different profiles of these different stigmas and look how that's associated with outcomes. And I'll show an example of that in a bit. So the main study in the US where we've been looking at this is what we call the WAVE study. And this is a study of the mechanisms and longitudinal effects of stigma on women's adherence and outcomes. And this is nested within the Women's Interagency HIV Study, or the WISE. And so we've been able to collect four waves of data on women who participate in this cohort. And if people are not familiar with the WISE cohort, it's been going on since 1994. It has been women living with HIV, and actually only in 2013 they added locations in the US South. So that's when we as UAB in Birmingham, also Jackson, Mississippi, Atlanta, Georgia, North Carolina, Chapel Hill, and Miami joined the cohort. So this is a cohort that these women, both women living with HIV and also at-risk women who are socio-demographically matched, come in every 6 months for research visits and get asked a plethora of questionnaires, psychosocial measures, physical exams. It's a pretty intense research cohort. And so we were lucky to get this grant and to be able to include a lot of stigma questions and even intersectional stigma questions in a subset of the cohort sites. I'll just add that this cohort is now merging with the men's cohort, the MAX. And they're going to be recruiting a bunch of men in the US South. So I think it's going to have some exciting potential going forward. It's a bit of an older cohort. I'll just give that also caveat because the cohort's been going on for so long, and they never, like when we started in Birmingham, I think the lowest age was 25 that we could recruit. So It's an older, middle-aged cohort. So in the part of this study, we had other aims, but aim 3 was really focused on intersectional stigma. So we wanted to look at, and we were able to look at sort of 4 different intersectional stigmas. We looked at stigma around HIV. We looked at stigma around race and ethnicity or racism. We looked at poverty stigma, and we looked at gender-based stigma or really sexism. So those were the 4 that we were able to look at among women living with HIV, and we did use mixed methods research. And so we started out, this was an exploratory sequential design. We started out with qualitative in-depth interviews with women living with HIV, and then used that information to tweak these validated, nuanced, separate measures of these different stigmas, and gave those in questionnaires once a year for 4 years. So the qualitative work on intersectional stigma was led by Dr. Whitney Rice, who's at Emory. And so she really spearheaded that work and has written it up in a really nice article in Social Science and Medicine, I think. And so this article was based on 76 qualitative interviews with women living with HIV in these 4 different sites, Birmingham, Jackson, San Francisco, and Atlanta. And we did the sampling that we wanted to sort of get variation in our sample in terms of race, ethnicity, income, sexuality, and age. And so what we found is that these women did talk, in addition to the stigma that they felt around their HIV status, they did talk a lot about stigma related to being a woman, to being Black, or to being a white woman in a multi-racial relationship, and also stigma around poverty. But they also talked about stigma around incarceration experience, age, and weight. But I think this quote is what really kind of gets in the essence of why it's so difficult to disentangle intersectional stigma. So this woman says, "All my life, I've always wondered what people discriminated against me for. Is it because I was Black? Is it because I was biracial? I never knew if people were discriminating against me because I was HIV positive, because I was a woman. Honestly, I don't know what. I can't really pinpoint. I just know that something. I guess it's like a gut feeling. Something just didn't feel right. Like somebody insulted me, and later I'm like, what was that for?" So really, it's even in qualitative work, it's to ask the questions, to elucidate some of this stuff is very challenging because it's not often the way people think about it. So here are some quotes, just some of the quotes that show some of these intersectionalities. So this one says, "The men can do what they do and the women shut their mouths and take it. Women can't do anything about it. That's the whole culture. They downgrade a lot of us women who are prostitutes. They're street girls, so HIV is what they get." Here we've got sexism, we've got sex work stigma, and we've got HIV. Here's another one. "Yes, stigma affects me personally because I'm a woman that's living with HIV and I'm a Black woman too. So I'm just I'm calling out these things, a woman and then a Black woman, because these are the things that are stigmatized the worst. So racism, sexism, HIV. And I like this one on poverty stigma. People just talk down on the poor women. And to the rich ones, people are just sorry that it happened. And then people are off to another subject. The poor ones, people are just constantly beating them up. Poor women already feel bad about their HIV status, but they are constantly just being reminded of it. It is a battle." And I will say that, so subsequently, we have a paper out on poverty stigma and HIV outcomes, quantitative paper, and this was actually very strongly and significantly associated with viral load, non-suppression, and non-adherence, and elevated CD4. So this is actually a stigma that is really strongly associated with HIV outcomes. Sometimes when we measure HIV stigma, we don't see as strong associations. So I think poverty stigma really deserves more study in a lot of health fields. So as I mentioned, for the quantitative part of our study, we are using latent class analysis, and this work is being led by Dr. Andrea Norsini-Palla and Dr. Turan. So this is, a person-centered approach. And so you assume that people experience these stigmas of different types and different levels, and that, these heterogeneous groups have different outcomes. And so using these types of tools allows us to, we're able to identify different subgroups of women who experiences these stigmas in different ways. And so we've looked at how these profiles vary according to these outcomes. And so these results were presented at the AIDS Impact Conference last summer, but they haven't been published yet. But we basically have sort of identified 5 different classes in the data. We've got a group of women who report low discrimination on all of these, all 4. So it's poverty, gender, HIV, and race. We have women that just report some gender and racial discrimination, not the others, or low on the others. We have women who report some poverty and HIV discrimination together. And then we have a group here that they've got high poverty, gender, and HIV discrimination, and some racial discrimination. And then, oh, what did I do? Something bad. Okay. And just to show the last group, high discrimination on all, which is actually the smallest class with only 31 in that class, so that might influence the results. But not to go into too much detail, but I can just show you that these last 3 classes have very significantly lower odds of ART adherence, HIV visit engagement, and undetectable viral load. And that's true for both of those classes, all of them significant. The last class only showed a significant effect on adherence, but it might be due to the sample size in that class. So we think this is, we still need to disentangle, what the differences are, what they mean, but I think this is a promising method. And these are just some of the people that are involved in the WAVE study, which there are a lot of them. So I just wanted to present the work of another of our colleagues who's working on intersectional stigma, and this is Dr. Christy Stringer, who is at Columbia University right now, and who you met last week. And when she was at UAB in Birmingham, she did a mixed method study of people living with HIV who are also using drugs. And so she was really interested in how both HIV-related stigma and substance use stigma affected HIV behaviors and outcomes for this population. And so she has some pretty interesting findings. In this population, remember these are all, current substance users, she found that HIV stigma did not predict their adherence, ART adherence at all. It just wasn't significant. But what did predict people's adherence was their anticipations and fears of drug use stigma. So that significantly predicted less adherence to ART and remained significant even when you controlled for HIV stigma. In her qualitative work, she did find that people talked about HIV stigma a good deal. They said it impacted them. It made them feel like they had to hide their medications or avoid being in the clinic. But they really most passionately talked about the stigma that they experienced around their drug use, and particularly how it affected their patient-provider relationships. So even at the HIV clinic, where we think everybody's understanding and compassionate, but some of the providers really struggled, understandably, with people who were using substances. And so people said they were judged, stereotyped, treated worse because they were drug users, both in HIV clinics and in other types of health care. And it really limited their communication with their provider because they felt they couldn't be honest about what was going on in their lives. And sometimes then they got suboptimal care because the communication was not there about what was going on. And here are some of the quotes. I'll just read the last one, but this person says, even from the people you mentioned, social and healthcare workers, They treat you like you're a failure. They don't want to be bothered. They try to get away from you and you become a social pariah. Nobody wants to deal with whatever you've got going on. The other one is they pity you, and who wants to be pitied? Even the ones who want to help they just shoo you away or try to get away from you. So I think these are, this really, again, makes me feel like even in HIV care settings, we need to work on the issue of intersectional stigma. So what about interventions? Okay, we're starting to learn about intersectional stigma. A lot of people, of course, in the community who are living these lives realize that these are things that need to be addressed together. So what kind of interventions do we have? So there are some interventions that I work with health workers, so to try to change their attitudes, behaviors, and communications with people that live with stigmatized conditions. And so those can be with students, medical or nursing students, people who are currently providing care. Some interventions target all levels of staff in a facility, including the receptionists and the guards and the cleaners. And different formats, in-person workshops, seminars, videos. And there's a nice kind of summary or a review of this in an article by Laura Nyblade in EMC Medicine 2019. And a lot of those interventions do attempt to address more than one type of stigma. There, of course, are also interventions that work with people living with HIV or people at risk of HIV and community members, focusing on groups that do experience intersectional stigma, like African American women, or Black MSM, or transgender groups. And those are, again, both group and individual. Laura Bogart has an interesting example that you can look up. And there are a few interventions that are trying to work with both health workers and clients to try to break down some of those barriers. And there was a multi-country African study, which was really focused on reducing stigma in healthcare settings, but working with both clients and providers. And we have done an adaptation for that for the Southern US, the FRESH study, which I'm going to talk about briefly. I hope that clock back there is right. I think it is. Okay, good. Yeah, good. Okay. So FRESH, which stands for Finding, Respect, and Ending Stigma Around HIV. And I was very proud of myself when I came up with that acronym. I saw it on a truck or something. It was like Fresh Foods. I was like, yes, that's it. But this was an intervention, again, that was developed by William Holtzimer and others in a multi-country study that was in sub-Saharan Africa. And what we wanted to adapt it to address discrimination in healthcare settings in the US South. And so this is a very, hands-on workshop, low-tech kind of intervention where we bring groups of health workers and people living with HIV together. So it would be like kind of in equal numbers. So it might be 10 people living with HIV and 10 health workers. And one, we share with them local data on stigma that's going on in their locality, in their clinic, and also share general information about how stigma affects people living with HIV. This is based a lot on contact theory, so where we're bringing people together to get to know each other as people and really get them to actually work together and collaborate on something, which then the last element of it is empowerment, because in terms of people living with HIV, they are getting involved in an activity where they can address stigma, fight back against stigma, do something about it, instead of just trying to deal with it or cope with it or manage. So these are the kind of the core elements. So the latest iteration, it was about 1.5 days that people spend together, 1 full day and a half day, and go through a series of discussions and interactive exercises to understand stigma and think about what we can do about it. And so when the program was offered in Africa, there wasn't anything about intersectional stigma. It was all about HIV stigma. And we realized when we brought it to the South, okay, we've got to be talking about homophobia. We've got to be talking about racism. We've got to be talking about poverty. And so that was kind of the main modification that we made of adding a session on intersectional stigma And we have an exercise which was part of the original intervention, but it's really changed a lot. It's called stigma stories, where we have people get in pairs. It's usually a health worker and a client. And they tell each other stories about a time when they've experienced stigma or discrimination because of some aspect of who they are. And you will find that everybody has something to share, you know. Is it, you know, it's because, you know, you're from a Muslim family where in a largely Christian community, or, you know, because you're from Indiana, or, you know, I don't know, just a variety of things, that everyone has a story to tell. Then we switch up pairs and have other pairs tell their stories. It's really powerful, you know, and then the health workers hear these stories of these, you know, often, you know, young gay men, you know, growing up in rural Alabama, what they lived growing up, and it's just really impactful. So people feel that and they get that close connection. So we also talk about the outcomes of stigma. We usually do an HIV knowledge update that is appreciated by the providers and the clients, just so often if people don't know what the latest things out there are that can even drive stigma. We talk about challenging stigma, coping with it if you have to. And then we have them work together on activities to reduce stigma in their own healthcare environment. So planning some interventions or activities. So we were able to pilot this twice in Birmingham with very small samples. Overall, you know, very feasible, satisfaction extremely high. People really thought this addressed real and prevalent issues in their lives. We did some pre and post measurement, and again, sample sizes are small, but in general, the health workers became more aware that there actually is stigma and discrimination in their healthcare setting, which they hadn't really even thought about before. In the clients, we saw some decreased uncertainty about their HIV treatment. But what we're trying now is to test this on a larger scale. So we currently have collected baseline data from 6 different HIV clinics across Alabama and Tennessee. And these are kind of outside of major urban areas, so it's a little bit different environment. And so we did questionnaires, again, to assess what's going on. We also did focus groups with both providers and clients to figure out how they would like to do an intervention like this. So we'll hopefully be testing that soon. We also have a proposal to adapt FRESH for the Dominican Republic with a focus on MSM and transgender clients. So, and I would love to have ideas from people about other ways that we can deliver this. Again, we're not really using an app or technology or anything like this. So, but really, we do hypothesize that even if you do this, a small group within the clinic, that the messages and behaviors and attitudes are going to diffuse throughout the clinic and affect clinic-wide outcomes. That remains to be shown. So again, we have a lot of people involved in FRESH, and I hope we are able to take the work further. So I just want to finish up. These are some of the review that we did with the NIH Fogarty Center on intersectional stigma. We came up with some recommendations for intersectional stigma work. And so we did feel that in terms of measurement, we still need better quantitative measures, more nuanced measures that get at the essence of these experiences. We also feel we could use better interview and focus group guides for in-depth work on this issue, because it really does take the right kind of questions and probing to really get people to reflect on these experiences. We think there is value in getting some parallel measures for different stigmas, or at least the common elements. I mean, again, you know, it's pros and cons whether you want to have parallel measures or separate ones, but we think both could be useful. In terms of effects, I think we still need to know how the impact of stigma on health varies by health condition. So, you know, is cancer stigma a huge factor in lung cancer outcomes? We're not sure. Some people are trying to to study it. We also need to know how the effects of stigma really differ in the presence of people's different identities. I'm always a big proponent for looking at drivers and mechanisms. So are there some common drivers of all these stigmas? What are the mechanisms for impacts on health? And importantly, what are the pathways that are amenable to change? Okay, once we learn the pathways, we can include things in interventions that might actually move the needle and make a difference. In terms of interventions, so we need to develop strategies that address the unique barriers that are posed by intersectionality, but also try to capitalize on the solidarity and social support of shared identity. I think we need more work to figure out what types of stigma are best addressed simultaneously in interventions. It wouldn't make sense sometimes to include certain groups, but there are certain groups of people who, many of them are suffering from multiple stigmas that could be commonly addressed. And we always need to figure out ways to meaningfully involve those individuals who are affected by the stigmas in developing these interventions. And for the policymakers, we thought the policymakers should prioritize intersectional approaches to maximize the impact of their investments. And really the policies could really focus on strategies that simultaneously address multiple stigmas where it's appropriate. And I think all of us need to work to break down the silos between different disciplines, different health issues, to really work in interdisciplinary teams to come up with the best approaches. And just a few more acknowledgments. Again, this is the Fogarty Center who's sponsored some of this work and the authors on that article that I mentioned. And even though I think this is a pretty old UNAIDS logo from maybe 10 years ago or something, but I still like it, that really our goal is getting to zero, not 90, 90, 90, zero new infections, zero discrimination, and zero AIDS-related deaths. So thank you having me for World AIDS Day. I hope it's enjoyable. I hope it's enjoyable. I'm happy to answer any questions that people might have. Yes, sir.
Thank you for a really interesting and engaging presentation. I'm Tom Long, and I'm a professor of English appointed to the School of Nursing.
Okay.
And my field is medical humanities, and much of my published work has been around the figure of the pariah, the sexual, cultural pariah in the context of HIV/AIDS. But with a kind of twist to it, that is, the pariah for whom the pariah status becomes an emblem, an embracing the stigma, and then brandishing the stigma. And I'm thinking particularly of some work I've done on AIDS zines. Like Infected Faggot Perspectives and Diseased Pariah News. So does your work look at that at all, that phenomenon of the stigma that becomes an emblem of self-identity?
Well, I'm definitely aware of it, and I think it's very important. Some of the work that we've been doing around PrEP, pre-exposure prophylaxis. So we worked on at our team in developing a scale of PrEP stigma, and conversely, what the article is now going to be called PrEP empowerment, not PrEP stigma, because people really, it was when you embraced that identity and saw that you were doing this positive thing. I think that's a little bit of it, but I think also we've also seen that people are able to deal with stigma more when they actually acknowledge it. You know, that you acknowledge it, and it's out there in the community, and then it's something you can fight against, right? And so I think some of the research that we've done have supported that point. So I appreciate that. Thank you. Yes.
Hi. So one of your earlier slides, you had waitlisted. That's the area that I work in. And I attended a cultural competency training last year. And actually the stigma that kind of really got people emotional and upset was the weight one, even though people may have had other intersectionalities in addition to that.
Yes.
And given that many people living with HIV are actually dying of chronic disease, and so, you know, eating healthy and being physically active are really important. I'm wondering if that's come up, if weight has come up, and if you see a role for that, you know, in these kind of interventions.
Absolutely. Weight stigma is huge, and you would be, I mean, I don't know, people who are studying people with HIV, you would be amazed at the obesity rates in people living with HIV. It's actually much higher in the general population and very different than people's kind of traditional stereotype, you know, people. And so, and in women, I feel like maybe 50 or 60% of the WISE cohort are classified as obese. And so it is a huge issue, and one of our assistant professors, who is a product of this institution, Kaylee, was it Burnham? Burnham?
You can call her Crockett, we call her.
Okay, Kaylee Burnham Crockett, who did her doctoral work here and then did a postdoc with us and now is an assistant professor in my department. She is focusing on weight stigma and body stigma around women living with HIV in the WISE cohort. And so she is right now doing qualitative interviews. It was interesting when she first started, there was kind of, stigma research is so interesting. I mean, we've had a lot of pushback because some people don't like you to ask stigma questions if they feel like stigma questions in themselves are stigmatizing, right? And it's hard because stigma is not a good thing. It's a bad thing. And so even including internalized stigma questions in the cohort has been problematic from time to time because more the researchers actually than I think the participants get worried that people are going to be upset by items that say, you know, I feel like less of a person because I have HIV, or I feel this having HIV in my body is disgusting. And those are really difficult things to deal with. But similarly, for weight stigma, people in the cohort were really worried that women were going to be really upset about answering those kind of questions. And so she is doing this qualitative work first to make sure that the items are something that people don't find offensive and resonate. And then she's going to be adding those items to the quantitative cohort. So yes, a real area of interest and very important. And I'm sure she would enjoy talking to you about it.
So I'm just gonna ask you this question.
Okay. Uh-oh.
just because I'm kind of struggling with this myself.
Okay.
So and actually I'm struggling with this in a lot of different levels. Well, not levels, but definitely certain multiple areas. Actually, I guess you could say multiple academic identities. I guess you could say I'm having
intersectional.
Yeah, so I'm you know, from multiple places. Grant review as the editor of a journal.
Yes.
It gets a lot of stigma kind of stuff.
Right.
In my own work. The mantra of the year is, if you're studying stigma and you're not studying it intersectionally, you're missing the big picture.
Right.
Great, so tell me what measure to use and what's the perspective, and it's so important, and policymakers should include it in interventions, and we need more emphasis, and yet I find the approaches, you know, dissatisfying. I think that the analytical approaches are helpful to me. I mean, the thing is real, right?
Yes.
I mean, you know it from the qualitative interviews, right?
Right.
But where's the bereavement scale that taps the bereavement I'm experiencing for my pet, which seems to be more than for the other relationships? And I know I experienced that, but can you measure it? So sometimes things are important in human experience. We can say they're important, but that doesn't. And so, do you really believe that the intersection of multiple identity stigma predicts adherence better than just HIV stigma? I mean, do you know what I'm saying?
Mm-hmm.
So it's like we've got these really good relationships between HIV stigma and adherence.
Right.
It's so robust.
Right. Mm-hmm.
And that's not good enough. It has to, there's added value to the intersectional HIV, race, and gender stigma. If we could measure that true intersection, it would be more predictive than HIV?
Well, I don't know, like I take the case of this substance use stigma and the association with HIV-related outcomes. I mean, in certain subpopulations, I feel like that intersection could be really more predictive than just HIV stigma alone. I mean, especially with some of these identities that are really heavily stigmatized. And again, like, you know, sexual orientation and substance use being maybe the strongest. That, I don't know, and again, like HIV stigma, even though it's robust, sometimes the effect sizes are not huge, right? So I feel like we are missing something. Yeah. I don't know if Valerie wants to add anything to that.
That made me think of, so I think there's two things to intersectionality. So it's how are you like experiencing it that it's different, and I think one of the really great complications to it that you brought up in the beginning of the talk is that it's dimensions of vulnerability and also of strength. So I think when we think about intersectionality, we're always like assuming that it's all of these vulnerabilities mixed together, but I think it's actually, you know, Carmen Logie keeps reminding us that there's also strength in the mix. So we can't just assume, you know, I don't know that if we, you know, really account for intersectionality perfectly, that we're going to see worse outcomes all the time. But I think that what we see is like people's experiences of stigma are different, and that might shape the scales. And that the outcomes might be different, but not necessarily always worse, I think is the point. And so one thing though that, you know, if you think about one study that I really like is Lisa Rosenthal's study that you highlighted about gendered racism. And what's really cool about that is they made this really super specific scale about stigma experienced at the intersection of sexism and race. And then they predicted pregnancy distress, because these were pregnant women. And they looked at that, you know, their gendered racism scale, and they found that it was that it predicted worse like distress above and beyond racism and sexism. So to me, it suggests like it was a more powerful predictor.
So they used all three measures. They used the racism, the sexism, and then this intersectional scale.
She looked at she looked at all three together. Yeah, to see which one.
We can do that.
That would be very strong evidence.
Yeah, I thought that was a really interesting, but you know, then the kind of problem when you back out though is like, how do you do this at like a population level? Like she looked at two, but they're also experiencing poverty stigma or obesity stigma, so
to figure out which are the most salient ones. And I think, you know, as what Dr. Long was mentioning about the resilience and the power, you know, I think that's really coming in there when sometimes, if then you're getting together with other Black gay men that are experiencing this, then that's going to shift things. So I think there's value. I mean, I'm also not quite sure what we're going to come up with in the end. I mean, for interventions, I think it makes total sense, right? I mean, just to be really dealing with what the multiple things that people are experiencing, and then we'll see what we can see in terms of actual impact on health outcomes. But I think.
Thank you, everyone.
Okay, thank you.